weight neonates using 3 new predictive models from Ruth del Rio from Spain.
Hi, good morning. So I'm a neonatologist working in Spain, and I'm going to present you our work on mortality prediction in very low birth weight. So as we all know, preterm birth is the main cause of perinatal mortality, and clinicians and families face every day very difficult decisions regarding care and treatment of these patients. So it's important to have as many tools as possible to aid us and to individualize as much as possible the patient we have in front of us and give them the best care available. Now, as it was reviewed by Medlock in 2011, at that time over 40 mortality predictive models existed for preterm infants, and after the publication of this study, at least 8 new models have been published. So this is something that has been done for many years now. And the aim of our study was to develop and validate new mortality predictive models for clinical use to be used for preterm infants born in Spain. Now, this is again a retrospective study, and we use as a database data collected prospectively is the National Spanish database. And for the training of the model, we picked data of newborns born between 2009 until 2012. And first we performed a bivariate analysis of all the variables included here as related to death, and included only the variables if the P after different statistic tests was under 0.15. And then we performed logistic regression at different time points of the included variables to develop the final models. To assess model performance, we used a different statistic test to assess for precision, for accuracy and calibration and the overall performance. And we developed 3 models, one to be used prenatally, one to be used at the first 24 hours of birth, and one to be used during admission. We then validated the obtained formulas in the same database, but using patients included that were born between 2013 and 2015. And again, we used the same model performance statistic analysis. And finally, we developed an online tool that is easily accessible. And here the tool I will show you in the results gives you a mortality score, and we have decided to include 2 additional cutoff points, because what the calculator tells you finally is if the patient is very likely to survive, very unlikely to survive, or in a doubtful situation, with those negative and positive predictive values you can see on the screen. So this is the characteristics of the final patients included. For the development phase, we included over 8,000 patients. Mortality in these patients was almost 15%. And in the validation phase, more than 6,000 patients were included, with a mortality death of 12%. This is an example of how we selected variables, and this is for model 1, which was prenatally, which is a prenatal model. And as you can see here is the regression coefficient data with the odds ratio and the confidence interval data. Some of the confidence interval when we analyzed the variables were not significant, as was the level of care, and male sex was just significant, but was not significant when we analyzed for these years in the confidence interval. But nevertheless, we decided to include these 2 variables in the final model because they were clinically relevant and because they had been used in other models. These are the results of the model performance for model 1, 2, and 3. As assessed by different scores. As you can see, we had good areas under the curves for the 3 models. This is accuracy measure that was also good for the models. And this is of course for this cutoff points. And in the validation phase, again we had good statistical results, as you can see. So this is we've included a practical example of how the calculator finally works. This you can choose whether to use the prenatal or the first 24 hours model or the during a stay model. And if, for example, if we decide to use the hospital prediction during the first 24 hours of life, and we've put an example of a 28-weeker who weighs 800 grams and whose mother didn't receive steroids. This baby needed advanced resuscitation. His admission temperature in the NICU was low, and this would give us a score of 0.58, which is a very likely not to survive probability. If this same patient's mother did receive at least one dose of steroids, and his temperature, admission temperature is a little bit better, then the score changes. And if the mother does receive a full course of steroids and everything is like there's no resuscitation, admission temperature is normal, then this baby would be very likely to survive. So as a conclusion, we have developed 3 new models to predict mortality until discharge for preterm infants born in Spain. An online tool is available to improve implementation. The strength of our study is that it's a national cohort with a large number of patients involved, and models developed show robust statistic performance, and validation has been performed. But as limitations, we acknowledge that families were not involved neither in the model development nor to assess the final results of the model. We've not validated results in other populations, though this is something we have planned to do, or plan to do. And as a general limitation with all these models, we don't know what's the clinical impact this having this information will have on clinicians and on families. And this is a major limitation, I think, of all these kind of models. So I'd like to finish with a picture of nurses and doctors and families celebrating World Prematurity Day last November in our hospital. And I thank you for your attention.